Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Hey everyone, welcome to the Friends of NPACE Podcast. You know me, I'm Terry Schmidt. I'm so grateful that you're joining us today because I get to have a panel discussion with some of my favorite people and some of the greatest minds in the APP professional world, in the NP world that I have ever known. And we're going to keep it real today. We're going to be honest and humble and maybe have some differing opinions. But if you are thinking about NP school, if you are early in your career, or if you've been a nurse practitioner for a while, this is going to be a discussion for you because we're going to talk about what you wish you'd known before becoming a nurse practitioner and maybe a piece of advice that you would give yourself. So I'm going to let the panel introduce themselves. Indira, let's start with you.
Hi, everyone. My name is Indira Mauer. I live in the beautiful sunny state of Florida. I've been a nurse practitioner for 16 years now and in nursing education for 19, almost 20 years. And I absolutely love it. It's the most rewarding aspect of my career, I have to say.
Thank you, Indy. Dwayne, you want to go next?
Hello, everyone. Dwayne Aline. I hail from the great state of South Carolina, but I claim New York as my place I was born. I'm a clinical associate professor at the University of South Carolina. I teach primarily the acute care nurse practitioner programs, also teach DNP and also undergrad. I also work as a acute care nurse practitioner, hospitalist at Prisma Health Richland. I've been a nurse practitioner since 2008, and I've been in academia since 2020. First, I didn't love it, but now I've grown into it, and then it's a major part of my life. So it's great to meet everyone.
Thanks. I appreciate that. And Danielle, you're up next.
Hey y'all, I am Danielle McCamey. I'm an acute care nurse practitioner. I've been in the acute care game since 2011. I've been in nursing since 2003. I can't add it up, so I'm just going to drop the years for y'all to add up. I've been in academia for 3 years now. I am currently the Associate Dean for Clinical Partnerships and Innovation at University of Maryland School of Nursing. I teach in our DNP program. I have a lot of hats, but I'm in my NP hat today. So thank you for the opportunity to be here, Terry.
I'm so glad you're here. And last but not least, Stephen, you want to introduce yourself?
Sure. I am Stephen Ferrara, family nurse practitioner by background, and have been in NP for 26 years. 26 years is what I'm going to go with. And I am a faculty member, clinician, the immediate past president of the American Association of Nurse Practitioners. And like all of us, wear lots of different hats, do lots of different things, and hopefully, can share some insight into our wonderful profession. And, I look forward to this conversation.
Thank you so much for being here. And Sandra has joined us too. I'm going to send her our invite again because this is how we roll. We're so good and flexible here. Sandra, do you want to go ahead and introduce yourself? Can you hear us? Nope, we'll wait for her to join. And now my email's pinging. We're all keeping it real, right? So I'm Terry Schmidt, and the audience knows me. And like you, Stephen, I've been a nurse practitioner 26 years this year. A little painful to say. I know. I look really good. Thank you.
Yes, you do.
Miss Clairol and I are friends, just like that. I appreciate you all being here because you've seen both sides of it. You're all practicing, teaching, leading, and you've been doing this a while. So if we're starting with advice, what do you wish you'd known before you started as an advanced practice provider and a nurse practitioner? Not everyone at once.
Well, I'll start. I mean, I always say this when people ask me this question. I wish that I had acquired mentors early in my practice and not necessarily heavily depend on my preceptor. I was fortunate though that I had the service line that I still practice with, that we had a lot of strong preceptors that were invested in our success. But I wish that I had acquired other mentors to just get an opportunity to think about my career path differently, think about different other opportunities that I could have leveraged or took advantage of early on in my advanced practice world. So, mentor.
I think that's good advice, and a mentor early on.
I agree. I feel like that collaborative support is crucial throughout your nursing education or family nurse or nurse practitioner education, but also beyond, just to have that collaboration, to have a second set of eyes. Review this case with me. What do you think? I feel like that's invaluable.
Yeah, someone that's not giving you a grade that might tell you the truth. Sandra joined us. Sandra, do you want to introduce yourself really quick?
Yes. Sorry, I'm Dr. Sandra Deering. So, hi, Indira. So, I'm a family nurse practitioner. I actually work in psychiatric med management, and I do some faculty work. So, I've been an NP as many years as I've been married. So, since 2003. So, that's how I always know, because I got graduated the year I got married. So, and both are still working. So, that's good.
Amen to that. Nice. Thanks, Sandra.
Sure.
I don't know about you guys in acute care, but I was going to ask this question about things you wish you'd known. When I went to NP school for family nurse, it was completely different. It was not bedside nursing. It really wasn't. I mean, I knew how a body worked and how to do an assessment, but beyond that, I was like, wow, I don't know anything. Do any of you feel that?
Yeah, I kind of felt that way. But for some reason I had more confidence. I'm not sure why. So I was trying, because when I kind of thought of that, I actually had more confidence, probably because I worked in the ICU. So I had more confidence going in into the field of becoming a nurse practitioner. And I was kind of zoned in on becoming a nurse practitioner since I was at LPN. So that was in 1998. So a nurse practitioner, I said, that's going to be me one day. So I was really, zoned in. But one of the things I did wish I knew before becoming a nurse practitioner is the value of being dual certified, because I was kind of going back and forth between FNP or ACNP at that time. Now it's AGACNP, but I was like, which one? And I only chose acute care because I was in the ICU and I knew I like fast paced. But now seeing the value of having versatility, in the work environment, especially now, being able to work in urgent care clinics and the hospital, and even in teaching. The more versatile you are, the more useful you are, the more marketable you are. So kind of thinking of the long term, I probably would have, kind of ventured into both and just get it over with. Now I have no desire to go back to school, but that's one of the things I wish I knew, the value of having dual certification.
Yeah, I agree.
Yeah.
Stephen,
I think it's interesting. When I was very first an NP, just to offer something. So I had been a nursing supervisor and I'd been a critical care nurse. And they hired us as FNPs into the step-down units in the local hospital where we worked. And the first day I was writing orders and a patient had low urine output. And the nurse said, can I go hang a bolus? And I had a moment of like, my first answer was like, sure. And then I thought, what if they have a stone and it's blocking the ureter? And that's why there's no urine output. What if they're actually fluid overloaded? What if you have that moment of like, when people say now the pen is in your hand, quote unquote, it is a very different moment when it is 100% on you. And I'm sure I'm the person who, as a staff nurse, was like, I know what needs to be ordered. I know what needs to be done. And then the pen is in your hand. and all of a sudden you're just thinking at a different level.
Yeah, I think that's a great point.
And I think that circles back to that whole collaborative support, right? I feel like we all felt uncomfortable. Hopefully, I tell my students, it's good that you feel a little bit uncomfortable, because I feel like we need to normalize that we can't know everything. We don't know everything. When we feel like we know everything in healthcare, something's wrong.
Yeah.
And I feel like that's dangerous.
I agree.
Yeah.
Try
And-
working with a bunch of surgeons.
Yep.
That's my practice.
Yep.
Yikes.
I asked our lead intensivist one day, like 6 months into my role, and I said, when am I going to be 100% confident of the diagnosis? And he's like, Sandra, I've been an ICU physician for 25 years, and there's still days where I'm not 100% confident in the diagnosis. You just make the best educated guess that you can. You pull the puzzle pieces together.
Yeah.
You make a guess, you put a plan in place, and you reevaluate.
Agreed.
Yeah. And I echo all these sentiments. I feel like I've been working in the health policy area so long, and what strikes me is what I didn't know at the time is the nuances of NP practice, not only within your individual state, within your individual institution, how that differs across all of these different settings, which it should not, right? Like we're all prepared to practice as nurse practitioners and take the board certification exams and do all what we're prepared to do. And then, you get to your practice and you can't sign this form, but you can sign this form, or you can do this, but you can't do that. And it doesn't make any sense. And it's literally taken my entire career to understand these nuances, to try to get involved, to change for what I consider these archaic practices, so that we have a practice that could be viewed from afar that's the same, no matter really the setting. So I didn't know that.
No, that's a great point. I currently hold 11 different state licenses, and I practice in each of those states actively each week. And the difference from state to states, and I had been teaching students across state lines for years, just thinking, this is the thing.
Yeah.
Oh no, it's not. You can't write for gabapentin in this state, but as you're a nurse practitioner, I can't see patients telehealth in my home state I was originally licensed in, because I'm not smart enough there to do that. And I lost my South Carolina license during this last year. I didn't renew it because they dropped that as well. And I'm like, well, one day you're smart enough to see the patients, and the next day you are not.
Right. Yeah. It's not even day, it's by the hour. You were just doing it in another state, telehealth, and now you can't. It makes zero sense. And we need to fix that.
But also circling back to the policy thing, because right now we're just in a policy-rich environment with the current state of affairs. That's another, thing that I wish I knew early on, was the value and the power of being involved in policy, and that understanding the spectrum of being active and engaged. I've always viewed policy and that I have to be out in the streets with a bullhorn and, with the sign, but not recognizing like, oh, I just submitted my public comment yesterday. That's being active and engaged and aware in, the shaping of the policies that shape our practices. And so I really wish that I had that fire lit, because I will be, more committed to donating to my PAC, and more committed to, supporting organizations that are lobbying for things that are important for my practice. Because it just didn't connect to me that like, oh, the reason why I can't prescribe that, or I can't do this procedure, like, or I can't pronounce this patient has expired, because the policies and the laws and the regulations, that I'm just kind of like moving through, because I'm like, it doesn't really impact me, so I'm great. And it's like, oh no, it actually does. So I wish I got that epiphany early on. But now that I got it, like, I'm out here in these streets with a bullhorn, so.
She is. It's good. I think that's something we don't do a really good job of in NP school either is this is not that bedside nursing job that you're going to do a 12-hour shift and go home or work 2 12s a week or 2 12s a month and walk away from. Like once you're at this level of practice, not to sound shallow, but it becomes a piece of your identity and you have to take it with you, right? Wherever you are in every circle, and you got to be involved.
I didn't learn about policy until I got my doctorate. That's when we had to do a health policy course, and that's when I fell in love with health policy because I didn't even know this is what it requires for us to do these things. And I said, wow, because we had to do a health policy assignment where we had to, look up, we had to create a policy and figure out how to present it. And that's when I fell in love and actually became involved and that was 10 years after I became a nurse practitioner. So I was completely clueless to what happens behind the scenes. So I think definitely, and so now I encourage my students, and I went to the State House at South Carolina the other day. What I noticed, there was quite a few nurse practitioner students. So I'm glad they're being pushed into it. Even nursing students, I say, hey, get involved early. I was stationed with one because I was handing out packets for people that were going to see the legislators, or handing out packets, and I was working with a nursing student, and I was telling her, get involved early because this is going to affect you in the future. So just to see now that we're proactively pulling in students, whether they're undergraduate or graduate, and they're seeing what happens behind the scenes and why it's important to get involved early, I think that's a good thing. But I didn't have that as a student.
Yeah, I think that's really good. So the other side of that too, Dwayne, is that assignments matter. Like get involved and do what you're doing because it might feed into something else you do in your career. It's not just checking off boxes to pass a course. Yeah. What was harder than you expected about being an NP student?
I'll say, because at that time I was in school, I had a child. So it was harder than I expected, especially towards the last semester. But like I said, I was zoomed in and focused. I was ready because I even changed my job hours from weekends only to get to the last, the busier clinical schedule. So, but that's just the hardest for me is having a child and trying to get through the heavy courses towards the end of my program.
I would agree. I just wish that they did my program, I just wish that we did NP education where it's like we get all the didactic stuff out the way and then we can just really spend like the last year and change just in clinical, because I felt like it was like, all right, great, we have courses and then we have clinical and then so it just kind of felt like, just that yo-yo impact and trying to like synthesize things and actually looking for opportunities to seek out those competencies in a consistent way. So, because sometimes clinical, site rotations, like the day is hit or miss in terms of like what you'll be able to do. And then it's just, so I wish we kind of restructured it so we could just focus on clinical for like the last year and change of our program.
Yeah. What do you think about students trying to work while they're going to school? I mean, some of us have to. Is that like?
Well, I know they do, but I always warn them. So I always warn them, if you're going to work 40 hours, you're going to have to adjust your schedule because that will take up your time. Students still try to work 40, 60 hours. Some students, usually at least once a semester, I have a student come to me and say, I normally get A's on all my classes. And I'm struggling. I don't know why. And the first question I ask is, how many hours do you work? Do you work overtime? They look at me and I work 60 hours. You can't do that. You got to come back your hours. You got to give yourself your brain. I tell them to think of their brain as a muscle because you're constantly thinking as a nurse. People don't realize that you're using that brain. So you're going to get tired and you try to use your brain to study and it doesn't work.
Yeah. I think for me, what was difficult to get my arms around as a nursing student is when we did start clinical, that it became very clear to me very early on that I had to prepare the night before clinical every week. And you couldn't just walk into the clinic like a passive receiver of information, so to speak. You had to walk in like either I learned that it helped me to look at the schedule a day or two ahead of time if they would let me, to see what the complaints were so that I could walk in the door reminding myself what the guidelines for hypertension were, or what the guidelines for, osteoporosis were. And you can't just show up like you're showing up to a shift on the unit and just not have been prepared, especially in OB, where we had to do an entire 150 hours or whatever in OB. And that was an area that I had never delved into other than my own, personal history, which I had no kids at the time. But to walk into, large volumes of knowledge and information that frankly you just don't have, even though the didactic work in the class was fine and good, but the prep you had to do the night before clinical, in my opinion, to learn what you needed to, right? Because you'd be going room to room and be like, oh my gosh, okay, that's good. I got to remember what GERD is about. But you're going so fast, you almost don't have time to remind yourself what you need to, like, you know what I mean? Prepare for. I mean, it was, to me, that was the biggest, I guess, misnomer, is not really realizing that I needed to prepare every night before I went to clinic.
Yeah.
I think that's
For me, the struggle was how dramatically the nurse practitioner role stretches beyond just that clinical knowledge, managing time management, right? Seeing your patients, a complex EHR, right? Documenting everything, and then the productivity that you're responsible for. All of that, just kind of managing it all, that was huge for me to transition from the RN bedside role into the nurse practitioner role. That was quite the transition.
Yeah. And I'll add, I mean, I was one of those full-time workers. My nurse manager loved me because I worked every Friday, Saturday, Sunday, and med-surg ortho. But I was constantly trying, changing roles, and it was hard. One day, you have a floor, full of patients, and then the next day you go and, there's a day full of patients scheduled, and the work is very different, right? So I think it was trying to manage that. It goes fast. It's a lot of work on your own, and I think we need to be honest about that. I don't know if that's advertised as much as it is. You have a lot of work to do on your own, and you have to do it. And back in my day, they didn't even have computers. No, I'm kidding. There were computers. There were computers, but it was just it was a different setup.
Well, in the staff nurse role, when you're hired by a hospital, you walk in and they hand you an orientation packet. And I try to say to students, as you're getting ready to go into a job, you need to realize they're not going to hand you an orientation packet. If you don't know renal very well, you're going to have to say, can I see every single renal patient for the next 6 months with somebody here that I can ask questions to? You are going to have to take responsibility and accountability to go out and get that information that you need, because they're not going to give it to you. And that's not even a negative environment. That's even in a supportive environment. You're still 100% responsible for figuring out what it is you need to know and how to get that.
Yeah, I think that's a really good point. Something that surprised me about school was that the most difficult clinicals, or the farthest away, or the most rural, were the best clinical sites for me to be, as painful as they were while I was in them. And Sandra, it was what you said. It was a full-time job just prepping for clinical. And I would drive an hour and a half into the woods and see patients, but that's where I really gained my knowledge. And sometimes I think students look for the safest clinical. They want the busiest, close to their house, the commute's not bad. But that's kind of where I found this is the right thing to be doing.
Yeah, I found the best sites were and I was lucky I had good preceptors, but I would have a preceptor who I would come out and say, of the room, and say, okay, it's either bronchitis or a URI. And he would say, go back in the room and figure out which one it is.
Right.
and come back to me and defend your position. And not in a negative way, but he was right that I would come out, and in my mind, I really didn't know which one was the right answer. I was frankly guessing. And he would say, you need to be sure, and I want you to defend it to me. And that really, really honed in for me, like, holy cow, because I have to be sure, well, at least, reasonably sure, once I'm the one seeing the patient, right? I have to come up with my first diagnosis. But being pushed at that level really helped me understand how many times I was frankly just guessing and didn't understand the nuances that differentiate one disease from another when they're similar.
I love that. And I feel like, and I tell my students often, take advantage of clinical, take advantage of every patient you can see, but go in there with a nurse practitioner mind, right? As soon as you read that chief complaint, what are your differentials that you're going to pursue or rule out? And walk in there knowing the why behind what we do. Anybody can walk in with a script of, okay, HPI, old cart, and run through, but know why you're pulling what information you're pulling from your patients, and start to develop that mindset of clinical practice, the clinical judgment, evidence-based practice. I think that's so important. And preceptors like that, Sandra, that's invaluable.
Mm-hmm.
Yeah, my best clinical was in what they called intermedical. It was like a nursing home, but the patients are really sick. Patients were on vents, required TPN, and at a time when warfarin was used, I had to actually dose warfarin. I had to figure out how to, now pharmacy does this, but TPN, my preceptor made me look at the labs and say, okay, how much glucose, how much sodium, how much magnesium, how much insulin. I had a patient that had a higher output fistula, and I had to look at the output and then measure how much fluid versus the electrolytes just to figure out. So now when I looked at electrolytes, I'm crazy over electrolytes. Now every time so it's made me expert and confident. And in vent settings, I had it, even though it wasn't truly ICU, but there were patients on chronic vents. I learned how to manage vents and all the and then one of the things I struggled with was infectious disease, and all these patients had all types of infections and weird blood culture growth. So I learned how to adjust medications and do antibiotic therapy. So that was my best. And so I actually did spend a summer. I actually paid for extra semester during the summer when I should have been off. I did a summer semester just to learn some more. That's how much I enjoyed it.
Are any of you precepting now? I'm not in my current clinical role.
I can't in my education role. I don't have time.
Yeah, my practice won't let folks get away without putting their hand to the investment in the next generation.
I like that. Well, I wish I could. Sometimes I think I learn more when I have a student, because it forces me to get back in and ask some questions, because I just get in a routine now, right, when I'm seeing patients. And I think it's kind of sad that I'm not precepting patients anymore.
I precepted, it's been a while, it was pre-COVID. I had a student, and it was interesting because I teach research. And I think by and large, students will say, I just need to get through the research course. And I don't know that they really care about why research is important and why it really is the difference between ordering the right medication and the wrong medication. And we had a mom who came to us whose kid could not tolerate stimulants. And she had found an article about a video game for ADHD. And she wanted to know, do we recommend it? It was like $100, so it wasn't cheap, especially for this family. And they wanted our recommendation. And the student was like, how do I know? And I'm like, well, first of all, we're going to do what I always do when I'm not sure what the answer is. I'm going to say, let me give that some thought and give back to you, because there's nothing wrong with calling a family back later that evening, tomorrow morning, much better than making a rash decision. Or let me consult a colleague and get a second opinion. All of which really means I just need to take a deep breath, go get another cup of coffee, and figure out what the answer is. But we read through the article together to determine whether it was an actual treatment that was worth something, or whether it was just, the guy who, invented Minecraft wanting to make more money by a different, video game. So yeah, and she really, in that moment, was like, oh, I just blew through my research course and I didn't really care about it. I'm like, this is why you care. Yeah.
But also, Sandra, to your point, like I think a lot of people put a lot of pressure, and I'll speak for myself being type A as an acute care nurse practitioner, working with surgeons. So that culture of perceived perfection, there's some God complex going there.
Mhm.
There's competition of, who can, spout out the latest whatever. But I have, curated my practice as after I kind of got beyond that competition piece, and essentially, I mean, unfortunately, in the areas that I work in, like you have to prove your competency and your resourcefulness and things and your skills, and technical abilities, because I come from the generation of like, I hate to say it, but you get pimped during rounds, like meaning people will call you out.
Mhm.
They'll single you and basically just ask you question after question. But all that to say, going back to your point, was you know, patients and families really value when you're honest with them.
Absolutely.
They want to know that you're human. They want to know
Mhm.
that you are willing to take the time to
Mhm.
take the best care of their loved one. And sometimes is being like, you know what, that is a great question. I'm going to, reach back out to my teammates or bring my collaborating physician, whatever the case may be. Like I find that really goes a long way when I'm just honest, and it makes
Mm.
me feel good because I'm like, look, let me get somebody, because we ain't about to here just be making stuff up for the sake of
Yeah, nope,
impressing who,
nope.
Exactly.
nobody.
Exactly.
Mm-mm. No, humility is everything in healthcare for sure.
Mhm.
Yeah, it sure is every day. And just when you don't have enough, you're going to
Yeah,
get a good
yeah,
dose that day of
yep,
Oh yeah.
humility.
yep.
Oh, okay. I want to take us down the different path of like advice or the resources. So we'll split this here and go into a part two, because then I also want to ask a policy question at the end of this, just to rile up the masses when we get done with the discussion. So I'll make a mark here. We're going to catch us on the other side of part two of this, and we're going to ask this panel what their advice is.